Okay, let's finish this slide on respiration. So, as I was talking about, if they don't get this compression of the thorax and the thoracic squeeze and expelling all that fluid, it can lead to TTN, or transient tachypnea of the newborn. Also, if a baby has meconium aspiration or anything like that, you can also get TTN. And what this is normal term babies are just having a hard time recovering from that transition and being able to breathe on their own effectively. So they are going to have these respirations above 60 for a moment, for a time, and then they'll kind of recover and then they'll get to go home. But they'll have to be in the NICU if you see this TTN. And of course, we'll have to gavage, feed them through an NG tube, because we cannot nipple or breastfeed or bottle feed, both of those, a baby with respirations above 60. Okay, so let's talk about how you recognize respiratory distress. And a lot of, I've seen on your ATI questions about how to recognize whether or not your assessments of newborns is normal findings or not. So a lot of this lecture is about the normal findings, and then I go over some like respiratory distress, some abnormal findings. But you're going to have to recognize when you see a question and it's giving you a situation, or you're going to have you have a bunch of test items that give you lots of different situations about a baby. And then you're going to have to recognize which baby is in distress, which baby needs better care, which baby is your priority. So really kind of think about that when you're learning this newborn assessment. Just really learn the vital sign parameters and what is a normal assessment finding and what is abnormal and what you might need to do about those abnormal. So it's just a little hint and a clue for you when you're doing newborn, is to really recognize when you're seeing something abnormal and that you're going to have to intervene and you're going to have to do something because that baby's in trouble. Okay, so respiratory stress is a very, very common occurrence, and babies end up in the NICU all the time. So it's just tachypnea, greater than 60 breaths per minute. You'll see different signs. So grunting, you see the grunting because they're, having atelectasis. So you'll see grunting. We see that all the time on the postpartum unit, and we'll recognize the grunting, and then they have to go to the NICU because there may be infection. There's just something else going on. It could be a problem with surfactant, but we just have to be able to take tests and figure out what's going on with that baby. When you see respiratory distress, you'll see retractions. It looks like the baby is kind of breathing in through a straw. So when they breathe in, it's so hard that it's like causing indentations in their chest. And I have a picture on one of the next slides of what retractions look like. If you've never seen retractions, then, or if you've ever seen retractions, you always know what they look like. The babies can get them, and adults can too, but babies that get them, they can get them above their clavicle, in between, so intercostal, so supraclavicular, intercostally, subcostally, substernally. You can get them all sorts of places, anywhere the skin can pull tight, showing that that baby's really working to breathe. You'll see nasal flaring because they're really trying to work at that breathing. You'll see, instead of the acrocyanosis, which is just the hands and feet turning blue, you'll start to see central cyanosis. So their lips are going to start turning blue. They're going to have an all over sort of ashy gray tint to them, and you know that that baby is in distress. You need to give that baby oxygen. And then anytime you see an asymmetry of chest movements, that's one of the assessment parameters that we do, you are going to maybe think about diaphragmatic hernia. Most of the time, diaphragmatic hernias are diagnosed with the ultrasound. What that is for some reason the diaphragm does not completely form. So what happens is, remember, the gut, the intestines are going to form much quicker than the lungs. The lungs are one of the last things to really fully develop. So the intestines move up into the lung cavity. So they're born, and it's usually on the left side. They're born with a very small lung on, say, the left side. And so they have gut up into their lung filled, which should be their lung. And so that is a medical emergency. These babies will be life flighted to Primary Children's because they need surgery. And then they will be watched for a lifetime, really. They have lots of cares. And then we all know what a pneumothorax is. A pneumothorax can be caused from the resuscitation measures that we do with a baby, or any sort of high pressure ventilation that we're going to give these babies. So if anytime you see those kinds of things, we're going to suspect that there's something else going on besides just simple respiratory distress. So the next vital sign we're going to look at is heart rate. And it's 110 to 160, and we're going to, when a baby is born, that first assessment, we need to assess it for 1 full minute. Evidence-based practice after that should be 30 seconds, and we can multiply by 2. That is the most correct sort of way to, assess a baby's heart rate. We want to listen to the baby at the PMI, or point of maximal impulse, right here. It's the apex. It's between the 4th and 5th intercostal. You can see it right there. It's just right where that left ventricle kind of comes out. And it's where you will hear the heart rate the best. And you will hear a heart murmur on most babies after they're born, because a lot of babies still have that patent, which will come off the lungs like this and go right into the aorta. So it will bypass the lungs, but they'll have a patent ductus arteriosus for about 24 to 48 hours. So you'll hear a systolic murmur on a lot of babies, especially our young babies, our preterm babies. You'll hear those PDAs, and it is a systolic murmur. The next important thing, so respiratory number 1, thermoregulation number 2. And the reason why thermoregulation is so important, remember 36.5 to 37.5, really easy to remember. The reason why we care about thermoregulation is because babies cannot shiver until they're about 3 months old. So what they have is this brown fat, and it's distributed right here in their core, and it's distributed in the last trimester, last part of the 3rd trimester. So preterm babies don't even have brown fat to access. And what happens is when there's cold stress, the baby is kind of signal to burn this brown fat, and then as the oxygen circles past this brown fat, it's very highly dense tissue, it will warm up the blood and therefore warm the baby up. So they're very inefficient thermoregulators on their own. That's why preterm babies are in incubators, and the really, really small ones, 24-weekers, we don't even dry them off. We put them right into a Ziploc baggie, because their skin is so translucent. They have no fat. We put them right in a Ziploc baggie and just pass them through the window, or just pass them right into the NICU, into a safe environment so that they can, heal or grow the best they can and have a chance for survival. So when they are cold, their rate of oxygen consumption increases, and they'll start blowing through their glycogen stores. So if we can keep them thermoregulated, it promotes proper growth and then stability for them to have a good outcome. So when you see heat loss, it happens in 4 different ways. So this is just normal 7th grade biology. So you can experience heat loss with conduction. So anytime you place a warm object onto a cooler object, in this case a warm baby onto a cold surface, that baby's going to get cold. So we put them under radiant warmers, or we keep them skin to skin with mom. Either of those are great options depending on how stable the baby is. And we pre-warm everything that touches that baby. Blankets, hats, stethoscopes, anything that we can do to prevent that heat loss, we will do. So we want to be and our ORs are kept warmer than normal ORs, and our rooms are kept warmer, and we are always thinking about the thermal regulation of these babies. So convection is when there is a ventilation that is cooler than the body. So if they're out in an open crib and they're not able to retain or stay thermoregulated, we'll put them into an isolette because we don't want them out in the open air. The isolette gives them warm, humidified air to help them stay the appropriate temperature. And then evaporation. We take these babies right out of the womb. They're nice and wet. We dry them as quickly as we can because we don't want them to get cold just from the amniotic fluid. Also, when we give babies baths, we are going to check their temperature before, try to maintain their temperature throughout, and then check their temperature right afterwards so we know that they haven't had heat loss, that's detrimental to them. So the last one is radiation. I forgot what I was going to say. I was going to say something, but I can't remember. Oh, yeah, that's what I was going to say. So if there's the bath, we really time that bath considering the stability of the baby. Babies that aren't stable, we will not bathe them because it's going to interrupt their breathing and they're going to have higher oxygen needs. It could mess up their glucose. There's lots of things that bath is stressful for babies. So we're only going to bathe a baby once it's stable. And the next one is radiation. So putting a baby in an open crib next to an outside wall that's cold in the middle of winter, they have the risk of getting cold, so we want to think about that as well. Alright, so all exams and assessments either done with mom skin to skin or under a radiant warmer to protect that baby. And then if we need to, we're going to rewarm them very slowly. It has to happen not quickly because you can cause respiratory distress if you warm them too quickly or other kind of complications. So blood pressure, we're not going to go into too much here because it's not for term normal babies. That's more NICU nursing. And then we'll talk about the CHD later. I have a slide about that. So we're going to take some measurements when the baby is born. We're going to take a OFC. Gosh, I could not remember. So occipital frontal circumference. I want to see how big that head is. The head should be the largest part of the body. We're going to take the length from the crown to extended foot, and that can be tricky for a toned baby, a nice flexed baby. And then we're going to take a weight. We always kind of take pictures of that for our parents so they can, we held the baby up so we can take the picture of the baby with the weight. And also head circumference is good because if there is any sort of bleeding, then we know whether or not the bleeding is getting worse. And so we take OFCs, I believe, every week. It doesn't matter, but you just take OFCs when they're born, and then if they're in the NICU, we take them on a regular basis. So here's just kind of a cheat sheet about the whole head-to-toe assessment. The assessment that I talked about earlier was just something that we do quickly, vital signs, APGAR scores. And then this head-to-toe assessment, you can actually kind of postpone that for a little while to give parents and baby bonding time. You just have to have it done within 24 hours. We do it fairly quickly just to get it done. But you have 24 hours to get that done. So I'm going to pause here because we're at 14 minutes, and I'll come back and we'll start with the physical assessment of babies. This is that head-to-toe full assessment.